coming in, and I know we won't get to all of them, so I will send them to you separately and see if you can answer them through email. Thank you so much, Dr. Mutha, for your time. We are so honored to have you as our keynote today, and thank you for all you do. We really appreciate all your work. Thank you.
Thank you so much, and best wishes to everyone today, this next week, and for the future.
Thank you. Now I'd like to introduce Dr. Saima Kayani. She's a pediatric neurologist at UT Southwestern here in Dallas, Texas, with additional training in genetics. She's passionate about helping children with rare disorders and finding better ways to treat these children. Saima, it's all yours.
Sorry, can you guys hear me?
Yes.
Some technical difficulties, sorry. Can you guys see my screen?
We can see it, yes.
Okay, let me go to that. Sorry. Okay, well, thank you so much, Casey, for inviting me to speak and present in this platform. Today, my talk is going to be around the clinical features of Leigh syndrome as we know it. It is just
Saima,
going. Hello.
You need to swap your display. We're seeing the presenter view. If you go up to swap display, there you go. There you go. Perfect.
Okay, perfect. So I guess as I was saying, I'm going to talk about clinical phenotype and clinical features of Leigh syndrome. And what a great talk by Dr. Mutha. I think some of my talk will have overlapping, features, but I think it was a nice segue because as we discussed that moving into a future where we want to have clinical trials for rare diseases. And one of the challenges that clinicians and clinician scientists face is when these trials or these therapies will come to the bedside, there has to be clinical outcomes and clinical endpoints. And in a disease where we have genetic heterogeneity, we have phenotypic heterogeneity, finding those clinical endpoints is going to be a daunting task. And I think understanding the natural history of the disease, whether through retrospective data or through prospective natural history, is very important. In my point of view, I think we all understand that prospective natural history study will be the gold standard because it can also provide us with a standardized cohort or a placebo, sort of like a placebo cohort for future clinical trials. But in my point of view, we start with understanding the basics, going back to the retrospective chart review, understanding the natural history of the disease from there, and then producing or proposing prospective natural history studies, which will help us with the future translation of the basic scientific therapies. So my talk will be an overview, as I discussed, of clinical features of Leigh syndrome. Leigh syndrome, as we are all aware, was first described by Dr. Dennis Leigh in 1951. And it was a neuropathologic diagnosis made at that time. And another name for Leigh syndrome is subacute necrotizing encephalomyopathy. Leigh described a patient who presented in infancy with drowsiness, ended up having blindness and deafness and bilateral spasticity following a brief encephalopathic illness. As Dr. Mutha mentioned, the first link to the energy metabolism dysfunction was established in 1968 when a patient was diagnosed or when a patient was found to have lack of pyruvate carboxylase activity in their liver. Later on, the link to the mitochondrial respiratory chain dysfunction was established in 1977 in a patient who had cytochrome C oxidase deficiency. We have come a long way since 1951 and 1968 and 77, and we know that Leigh syndrome now, it's one of the most common mitochondrial disorders of childhood, which affects 1 in 40,000 children in US alone. So various groups have defined Leigh syndrome, as Dr. Mutha also alluded to, and he actually described that too. Leigh syndrome is a progressive neurometabolic disorder. It involves degeneration of central nervous system, and we see characteristic symmetric lesions in basal ganglia and subcortical brain regions, where actually the definition of Leigh syndrome and actual description of Leigh syndrome comes from. Now we know that it is connected to the mitochondrial energy production dysfunction or deficiency of respiratory chain enzymes. And we know the molecular basis of the disease as well. So combine all of these pictures together and you will get Leigh syndrome. And that's all of these 4 components define Leigh syndrome at this point. After the first description of Leigh syndrome, multiple case series have came out describing various clinical features of Leigh syndrome. As now we know that it's a multi-system disease. Failure to thrive is one of the most common findings we see in patients. Developmental delays and regression is seen in a lot of patients. Ataxia and movement disorder is also seen in many patients. Ophthalmologic disorders, oculomotor problems with abnormal motor movements of the eye muscles is also seen in these patients. Biochemically, we have elevated lactic acid in serum and CSF, and MRI abnormalities, as we discussed. A lot of these patients can have pulmonary problems, clinical issues with episodic apnea, irregular breathing, and they would need pulmonary support. So just reviewing this of all the literature review, I picked out this article which came out in 2014. It describes 130 patients. 77 at that time were had an identified genetic mutation. The rest did not. So you can see until recently, Leigh syndrome or Leigh-like syndrome. We know the genetic mutations for most of these patients, but there are probably other mitochondrial disorders or energy metabolism disorder that are just not known to us. And they present with the clinical features of Leigh syndrome, but we are not able to fully identify the underlying molecular basis in some cases. In this particular case series, 77 patients had genetic mutations, out of which 28 patients had a mutation in mitochondrial DNA, and the rest had a mutation in one of the nuclear genes linked to Leigh syndrome. Median age of onset is 7 months, according to this patient, but 80% of patients had presented by age 2. The most common clinical feature in this case series was abnormal motor finding. Again, mind you, this is not the presenting clinical symptom. This is something that patients were found to have after over a time period. So abnormal motor findings could be low muscle tone or hypotonia, abnormal deep tendon reflexes. Some of these patients had dystonia, spasticity, ataxia, which is lack of balance and coordination, weakness in their muscles, chorea, which is a form of an abnormal movement, and they can also have hyperkinetic or akinetic movements. Other features included feeding difficulties in 60% of the patients and failure to thrive in 16%. Now, it's hard to kind of like understand if it was an additive effect or there was some overlap in these numbers, But in our experience as well, we see that a lot of patients with Leigh syndrome will have feeding difficulties or some sort of GI disturbance or GI gastrointestinal system involvement. It can go anywhere from reflux to intractable reflux to motility issues to complete failure to thrive. In this particular case series, cardiac dysfunction was seen in 17% of patients, and respiratory dysfunction was seen in 50% of patients. So looking at the Leigh syndrome as a multisystem disease is an important thing when we, again, move from understanding the disease and taking it to a clinical trials, and then looking at the therapies that do not only target the brain, but also help us treat other systems as well. This graph is taken from this comprehensive review of SIRFAN deficiency, which is one of the most common forms of cytochrome C oxidase deficiency or complex 4 deficiency, and one of the most common forms of Leigh syndrome. In this case, you can see again, vomiting and feeding problems were seen in 89% of the patients, with growth failure in 95% of patients. Hypotonia and then developmental delay were the next in line, with 93% and 88% prevalence in this cohort. Developmental regression is another common finding that is seen in patients with Leigh syndrome. Gait ataxia was seen in half of these patients with movement disorders, which could be a different type of movement disorder, either myoclonus or chorea, akinetic or hyperkinetic movements in half of the patients in this case series. In these findings, we were able to do one of a retrospective chart review with CareServe Fund Foundation, with the help of CareServe Fund Foundation, and these findings are somewhat similar to what we were seeing in our cohort. Now, moving on to the neuroimaging findings, as we discussed, Leigh syndrome, at the basis of Leigh syndrome, the definition is that we see symmetric T2 hyperintensities in deeper brain regions. What does it look like? So in this slide, you can see, if you can see my arrow, this is part of the basal ganglia where we see these T2 hyperintensities. So when we say T2 hyperintensities, what does it mean? It just means that you're seeing a bright signal in a very particular sequence of the MRI, which is T2, or flare sequences, which are derived from T2 sequences. And these hyperintense signal, or these bright signals, they signify an underlying pathology or some sort of problem with the brain tissue. Over here in the midbrain, you also see that abnormal signal in the form of 2 bright dots in the back of the midbrain. In the brainstem, you see these abnormal bright signals kind of like extending towards the brainstem, extended throughout the brainstem. Now, if you look at the supratentorial white matter, in this particular case, it is relatively spare. And in most of the cases of Leigh syndrome, white matter or supratentorial gray matter can, at least initially, can look normal. Now, in cases of Leigh-like syndrome, you can see hypomyelination or abnormal maturation or myelination of white matter. And that's, again, something that is seen in patients with Leigh-like syndrome with a similar genetic mutation, but maybe a little bit of phenotypic heterogeneity, where we are seeing not the typical Leigh syndrome lesions, but a little bit different lesions than Leigh syndrome. Keeping in mind, again, if we are treating a genetic disease with a targeted therapy or precision medicine, with the idea of a precision medicine and a targeted, maybe say gene therapy, then including, thinking about the clinical outcomes, we have a very good biochemical neuroimaging, marker, but does that include all the patients who have their genetic abnormalities? Sometimes you can see a little bit of difference in neuroimaging findings, but here we are seeing the typical Leigh syndrome lesions that define the subacute necrotizing encephalitis. In this particular patient, this first MRI was done close to 1 year of age. And in second MRI, you can see that these lesions have been progressive to where in the basal ganglia on the upper right-hand side image, you see the extension of that bright signal, extension of the bright signal abnormality. And it extends further than it was before. When we go into the midbrain and the brainstem, you see that it has extended to the point where we are now seeing some atrophy of the brainstem and with atrophy of the cerebellum as well, which is part of the brain that is connected to the brainstem through and you can see here that we are seeing a little bit more atrophy in the cerebellum in this particular case. So the lesions in Leigh syndrome can be progressive. MR spectroscopy is another it gives another very good neuroimaging or biochemical marker for patients with Leigh syndrome. As you can see in the first patient here, we have this lactate peak. This lactate peak is a very specific marker for mitochondrial encephalopathies, including Leigh syndrome. And here in this patient with the mitochondrial DNA mutation, it's an elevated but inverted lactate peak at 1.3 parts per million, where we usually see the lactate peak. And whenever we see a lactate peak on MR spectroscopy, we usually send for genetic testing to rule in or rule out mitochondrial disorders. In the second example here, we have a 6-year-old with complex 3 deficiency and with a pretty prominent lactate peak at the same spot, which again is a very specific biomarker for Leigh syndrome. Again, it is specific, but how sensitive is this biomarker? We really don't know. And I think when we say Leigh syndrome and all these case studies, all these case series have been in a cohort of patients where we have genetic heterogeneity, which is unique to Leigh syndrome, and it is beautiful in itself, but at the same time, it kind of like poses a little bit of difficulty when you are planning to use this as a specific biomarker for a specific treatment for one underlying genetic disorder, which makes the case to understand these diseases as per their genetic basis, as well as I think we're just, like Dr. Mutha was talking about splitters and lumpers. So do we need to understand them from individual genetic mutation and the genetic basis standpoint, as well as from the phenotypic, the clinical phenotype standpoint? In this case review, they describe the distribution of Leigh syndrome-like lesions or Leigh syndrome lesions. And you can see in brainstem, 9 out of 17 children of the cohort had lesions in the brainstem, including the medulla oblongata, midbrain, and pons. And we can see that 11 had lesions in basal ganglia. So 11 out of 17 were in basal ganglia, 9 out of 17 were in brainstem. You can see the thalami, which is sometimes considered as a part of basal ganglia, but some people would like to consider it as its own entity. 3 out of 17 patients had lesion in thalami. So, and the rest, cerebral white matter, not in this cohort, they didn't see any changes. Cortex, cerebellum, atrophy and delayed myelination was seen in some of the patients, but you can see that most of the lesions, most of the burden of the lesions, these lesions is in the brainstem and basal ganglia. So something unique about the biology or developmental biology of these brain structures that are more needy, so to speak, of the energy deficiency that is produced by Leigh syndrome. And those are the places that are impacted first before anything else. Now, keeping in mind that all these retrospective chart reviews will give you some retrospective analysis and a cross-sectional analysis in some cases, but now would these lesions progress to involve the other areas of the brain, and how these lesions really evolve over time in patients is something that's that we really need to that we don't understand completely. In this case series, 7 out of 17 children had progressive brain lesions, and I'm not clear on how many patients they actually had a repeat brain imaging on, but 7 out of 17 had progressive lesions. Now, looking into the biochemical abnormalities, and this is something that we have Dr. Mutha has also spoken about. So understanding these biochemical abnormalities and getting an overview of them. So our main oxidative phosphorylation or aerobic metabolism depends on glucose metabolism. The endpoint of glucose metabolism is pyruvic acid. Pyruvic acid gets converted into acetyl-CoA through PDH enzyme, which is one of the most important enzymes in aerobic metabolism. As it gets converted into acetyl-CoA enters the TCA cycle, which produces these very important compounds, NADH, FADH2, that enter electron transport chain. Whenever we have a dysfunction of electron transport chain, you can imagine that there will be backup of the metabolites, because there is clog in the system, so to speak. So with this clog or block in the system, you get a retrograde effect where you get intermediates of TCA cycles that can be elevated. And what are those intermediates? Lactic acid being, lactic acid not an intermediate of the TCA cycle, but going back here, pyruvic acid converts to acetyl-CoA on one side, and it converts to lactic acid on the other end. And it is in equilibrium with lactic acid. Whenever we have excess pyruvic acid, you will have excess lactic acid, and that builds up, and that's a very specific biomarker for mitochondrial disease. Again, we're using the word specific. Is it sensitive? It's hard to say, because when I see elevated lactic acid without any other reason in a patient, I think of a mitochondrial disorder. But you can have normal lactic acid values and still have a mitochondrial disease. So again, looking at the lactic acid, all these case series or retrospective chart reviews on mitochondrial disorders, mitochondrial encephalopathies, Leigh syndrome, they describe lactic acid abnormalities as a very common biochemical marker. But how common it is and how the lactic acid is drawn, how sensitive it is something that is, I'm not sure that we understand completely. Other biochemical markers, you can see elevated alanine, reduced citrulline in a very specific mitochondrial mutation. Then you see citric acid intermediates, oxyglutarate, succinate, fumarate, malate. Again, for all the families here, we don't have to worry about all these fancy biochemical names, but these are the intermediate molecules or compounds that come out of citric acid cycle or TCA cycle. And clinically, if I see somebody who has had maybe a borderline lactic acid in their clinical picture is concerning for mitochondrial disorder like hypotonia, or they have had developmental delays, and I see that there are intermediates of TCA cycle in acyl-carnitine profile or some of the metabolic testing that we do, serum amino acids, acyl carnitine profile, that's something that kind of like, helps me and gives me a clue to target my genetic testing toward the mitochondrial diseases. We have touched upon it many times. With genetic heterogeneity of Leigh syndrome, it's well known. So we have the story of 2 genomes here, as one of the articles has reported it. We have mitochondrial DNA, as Dr. Mutta mentioned in his lecture. So mitochondria being an intriguing, interesting, and such an important organ that it gets to have its own DNA. And that's, how I look at it sometimes. But anyhow, mitochondrial DNA, which produces some of the mitochondrial proteins, and any dysfunction in mitochondrial DNA or any change in the spelling or any change in the instructions in mitochondrial DNA can lead to Leigh syndrome. And some nuclear genes, many nuclear genes actually by now, that we know can lead to mitochondrial dysfunction, because what they do is they make parts of this complex, intricate machinery that is present inside the mitochondria, electron transport chain. So we talked about, all these complexes because we check these complexes too. Like sometimes I send for complex 1 activity, sometimes I send for complex 4 activity. So what are these? This is kind of like a machinery that helps mitochondria build up energy. And it is connected to TCA cycle, as we established. So we have complex 1, complex 2, complex 3, 4, 5. Any deficiency in any of these complexes will lead to Leigh syndrome. And if we look at the distribution of genetic changes in different components of respiratory chain that can cause Leigh syndrome, we can have nuclear or mitochondrial form of complex 1. Complex 2 and complex 4 is mainly autosomal recessive. But then we have complex 5, and then there are other metabolic disorders that can lead to Leigh syndrome or mitochondrial dysfunction. So if you just put in all the genes, and probably this list is not as complete as Dr. Mutta's list, but complex 1 deficiency, if we look at complex 2, 3, and 4 deficiency, there are like multiple genes that help make us part of these complexes. And whenever a part is deficient or missing and your machinery cannot function properly, you will have a defect in energy metabolism and oxidative phosphorylation. Then we have some special genes like ECHS1 or HBCH1 that are enzymes that are inside the mitochondria, and they help us metabolize some other things like valine in this case, and any disruption in valine metabolism and these intermediates collect inside the mitochondria and can cause mitochondrial toxicity. So as a clinician sitting in, in this time and age and looking at patients who have rare brain diseases, somebody who comes to me with a clinical phenotype that gives me clues towards Leigh syndrome. Neuroimaging findings, again, is very helpful, because once you see Leigh syndrome lesions, then you see Leigh syndrome lesions in the MRI, and then it's just a matter of finding whether we are talking about a complex deficiency, electron transport chain deficiency, or some other way where our energy metabolism is disrupted. Biochemical markers are really helpful, as we discussed earlier. Molecular testing. We have gene panels available now, so you can do targeted testing where you can send for a mitochondrial DNA analysis, along with nuclear genes that are linked to energy metabolism disorder. And that when it comes back positive, then it gives you a very solid answer. Skin biopsies with fibroblast culture, and then looking at different enzyme functions in these fibroblasts can be really helpful and adds on, especially if your genetic testing is inconclusive with variant of unclear clinical significance. No proven therapies. I think I'm just, I don't know how much time I have left, but I'm gonna rush through these slides. And for now, again, as we have already established, there are a lot of clinical trials going on for different products, different compounds, different medications. But so far, we have not seen any proven therapies. There are no cure for mitochondrial encephalopathies in general and Leigh syndrome. Various supplements have been tried, and there is a value to trying these supplements, and we call them mitochondrial cocktail on the clinical side. So if you hear it, just know that's basically a combination of different compounds, different supplements. And as I said, there is some value while you're waiting on your genetic testing and confirmation. You can put these patients on biotin, thiamine, because there are genetic defects like biotin responsive basal ganglia disease that can look like Leigh syndrome. And it responds to biotin because there is a defect in biotin transport. And when it responds to biotin, it responds to biotin. So trying on biotin or thiamine, if there's a thiamine transporter deficiency, if we do have a specific coenzyme Q10 deficiency, you can try that specific supplement. Epi743 is a synthetic CoQ10 that has been tried in some clinical trials. Not an FDA approved drug, but something that people have talked about a lot. Riboflavin for riboflavin sensitive complex deficiency. So there are something very rare, but sometimes you can find a vitamin responsive mitochondrial encephalopathy, and it is good to diagnose those because these are treatable, and early diagnosis is the key. So mainstay of treatment for now for a lot of mitochondrial diseases is supportive care. These patients, they need feeding support. They need to be assessed for their pulmonary function. I didn't add cardiology, but they should have surveillance cardiac exams every year or 2 years based on what their cardiac health is and how their exam goes. And then therapies, PT, speech therapy, feeding therapy, occupational therapy, which helps improve overall general health of the patient, muscle health of the patient, and also helps improve communication. So that is the mainstay of the treatment again. And I think that's all I have for today. Thank you so much for your kind attention. Thank you for giving me this platform to speak. And I'm really appreciative of all the patients and families, and the resilience that you guys have is an inspiration for all of us. Thank you.
Thank you so much, Dr. Kayani. We do have a few questions. However, we only have time for one question. Performing an MRI to babies and small kids is especially challenging as they shall remain steady for a long time. This is why anesthesia is typically used. Mito kids are particularly sensitive to anesthetics. This has triggered seizures to my daughter. What is your experience with performing MRIs to Leigh syndrome kiddos?
Yes, and you're right. It's absolutely, it is tricky. We do have some guidelines for anesthesia in mitochondrial encephalopathies, but it is not complete, right? Because we talked about the genetic heterogeneity. So a patient with SERF1-related Leigh syndrome might respond differently to anesthesia